Hola, ¿cómo están?
Hola, Antonio, buenas tardes, ¿cómo vas? ¿Bien?
Muy bien, sí, ¿cómo va todo?
¿Terminó la cirugía a tiempo?
Terminó hace unos 15 minutos, llegué aquí a casa, no muy
Bueno,
tarde.
muy agradecido que nos acompañe. Ya te lo dije
No,
anoche y
no,
te lo vuelvo a repetir ahora. Pero bueno,
no, con todo gusto, muy agradecido yo que me inviten otra vez. Hola Alejandro, ¿qué tal?
Alejandro va a coordinar el módulo.
Hola Antonio, ¿cómo estás?
Bien,
Estaba
bien, bien, ¿cómo vas?
terminando de hacer
Ya
las
tenemos casi
conexiones.
todos los invitados.
Ah,
Si
ok,
entra
Sí,
ahí veo a
José y
Luis también. Hey Luis,
Antônio, como
bien,
estás? Tudo bem?
ya
bien,
estamos
bien.
todos, Jorge, así que vamos a empezar en 30 segundos.
Y Mateo Alberto no está, o sí está.
Está.
Sí, está. Ya están todos conectados.
Alejandro, eu estou em duas conferências ao mesmo tempo.
Bueno, por eso sos tan bueno, Luis.
qué nivel, Luis, ¿eh? Qué nivel. Hola, Eduardo Londoño, ¿cómo estás? Tenés la mano levantada.
Hola Jorge, no
Para
la tenía
salud.
levantada porque no tenía el link para poder estar, que tú me pediste el favor de que estuviera presente, entonces por eso lo hice.
Aquí estás, bienvenido Eduardo, muchas gracias.
Hola Alejo, un abrazo, ¿cómo estás?
Muy bien, muy entusiasmados.
Y por ahí vi a Antonio
Bueno,
también, mi gran
Hola,
amigo.
hola Eduardo, ¿cómo estás?
Oye, te veo en condiciones un
Antonio,
poco, llamaría yo, deplorables.
Ayer y hoy he estado todo el día en cirugía, ha estado un poquito fuerte,
Hey,
pero
Antonio,
Eso
bien.
está
you
bien.
do this for me in Spanish?
Absolutely, I
Hi
do. For
Matthew,
you.
how are you doing?
Hey,
How are you
They're
doing,
all
Matt?
talking about you.
vamos Alejandro, porque nos vamos a quedar sin
Dale,
tiempo.
empieza.
Bueno, buenas noches a todos. Muchas gracias por acompañarnos en esta nueva sesión del curso anual. Hoy vamos a tratar sobre las vías de abordaje para el cáncer de recto. Tenemos un panel tremendamente importante y Alejandro Moreira Greco, el otro director de este curso, que va a ser quien se va a encargar a partir de este momento de la coordinación del módulo. Tenemos también en el panel a Eduardo Londoño, que es el director de la ALAC Educadora, que nos honra con su presencia también aquí. Y bueno, y Alejandro, adelante, porque hoy el tiempo va a ser bien tirado.
Bien, gracias Jorge por la introducción. Sí, tenemos un panel excelente.
Alejandro, y muchas
Vamos a hacer
gracias.
las charlas en dos idiomas, en inglés y en castellano. First, I would like to welcome all the speakers and thank for your participation. And thanks also for helping us in the effort we put to endure and keep Latin American surgeons up to date during the pandemic. Hoy tenemos 3 charlas. Vamos a tener al doctor Nam Kim de Corea, que nos va a hablar del abordaje laparoscópico. Él es del Hospital de Severance de la Universidad de Seúl, Corea, presidente de la Sociedad de Coloproctología y de Cirugía Oncológica de Corea y editor en jefe editor de Diseases de Colon y Rectum y Annals of Coloproctology. Y además tiene un montón de otros títulos de honorarios en Corea. Lo tenemos al doctor Jorge Lagares, que de Estados Unidos, que nos va a hablar de abordaje robótico. Él es el jefe de la división de cirugía de colon y recto y director del Epicenter, del Robotic Colorectal Epicenter en el Hospital de Roper en Charleston, en Estados Unidos. Y lo tenemos al doctor Matthew Albert, que nos va a hablar de TATME, que es el jefe de cirugía colorectal del Advent Health de Orlando, director del Surgical Innovation Institute para la Salud Intestinal y es, como ya todos saben, el coinventor del TAMIS y el desarrollador del HealthPoint Pad que todos usamos. Y como comentadores tenemos al doctor Luis Romagnolo, que es cirujano colorectal del Hospital de Cáncer de Barretos y es coordinador del IRCAT de Latinoamérica. Y volvemos a tener al doctor Caicedo y al doctor José Guillén, que estuvieron la sesión pasada con nosotros. Así que a todos, muy buenas noches y bienvenidos y muchas gracias por participar. La charla del doctor Kim la vamos a ver en un video y él va a estar presente para las preguntas y la discusión. So, if you are okay, Dr. Kim, we are starting with your video.
Today, my topic will be the laparoscope approach for rectal cancer. Currently, 80% of rectal cancer performed by either laparoscope or robotic surgery in South Korea. In this table, I will show the 4 randomized clinical trials comparing the laparoscope with the open surgery for rectal cancer. Although ACOSOG and ALACAR trial failed to show non-inferiority of the laparoscope surgery compared to the open surgery for rectal cancer, you can see the Korean trial is conducted by South Korea, comparing the laparoscope surgery versus open surgery in rectal cancer, especially and the pre-op CRT was done. You can see the very low conversion, 1.2% compared to the other clinical trial, and the low CRM positive rate, and also low BMI compared to the other Western trial. And this is usually confined to the well-trained surgeons. Anyway, the long-term and mid-term and long-term oncology outcome has been reported recently. It showed no difference between 2 groups. Here is our hospital case volume. Average 1,300 primary colorectal cancer cases per year were performed at our hospital. Last year, you can see the impact of COVID-19 for total case of colorectal cancer cases. In our hospital, show decrease a little bit, but this year case number increased again. Anyway, out of them, the 70% of colorectal cancer by laparoscope techniques and 10% are robot, but usually they're confined to the rectal cancer. The remaining 20% still need open surgery. The reason why the prevalence rate of robotic surgery is still low, I think that the main reason is the robotic surgery is not reimbursed by National Medical Insurance System. Here are the couple of challenging issues in the laparoscope approach for rectal cancer. As you well know, all of you, first of all, to preserve the intact major rectal fascia in deep pelvis. That's the only way to get ideal resection. And secondly, to avoid the positive CRM, especially in the anterior located rectal cancer. And lastly, we all must try to preserve the pelvic autonomic nervous system, especially pelvic plexus and the neurovascular bundle, because these structures are very crucial for voiding and sexual function. The rectum and the major rectum is located at the pelvic cavity at the distal portion of the pelvis. As you can see, deep concave curved tunnel with a narrow bony space surrounded by urogenital structures and neurovascular bundle. A blue arrow indicates the deep pelvic dissection. At this level, as you can see, the anterior seminal and prostate in man and vagina in female, and neurovascular bundle is encountered. It is important to follow step-by-step approach. The boxed level of the incisal view of the rectal MRI, the area where a good pelvic dissection is definitely needed. I would like to show again the importance of levator ani muscle around the anorectal junction. In this slide, the membranous sheet of pelvic floor muscle is clearly seen. This is anorectal junction and the pelvic floor and the dentate line. Many young colorectal surgeons do not understand the deep pelvic structure, anorectal ring, and anorectal junction, and the pelvic floor, etc. As you can see, the at Caravan study and pelvic floor is a wing shape, membranous thin muscle plate, and funnel shape. Red box show that the relation between the mesorectal fascia and the pelvic floor. The complete mobilization of rectum, mesorectal fascia should be completely separate from the underlying pelvic floor, and then you can get complete TME specimen like the red box area right side. The deep anterolateral dissection was shown in this slide. For obtaining the complete distal mesorectum at deep narrow space, you must understand the mesorectal fascia is attached to the denubus fascia and parietal pelvic fascia and underlying pelvic floor fascia. We must, and then we can fascia to fascia dissection, and then we can get the cylindrical shape of TME specimen. Once the postural dissection is completely achieved, and during the deep anterior dissection, after DBF is identified, and dissection proceeds posterior to the denubus fascia, dissection is continued to the distal to the pelvic floor, while the rectal wall is retracted medially in attempt to reach pelvic floor. I call this gate approach. Doing the so, leave the rectum posteriorly and anterolaterally fully mobilized, while still connected laterally by what was previously called as lateral ligament. Once the adhesion is released between the mesorectal fascia of the lateral part of the rectum, then lateral pelvic plexus is exposed. Let me show the short video clips about the gate approach. This is a seminal vesicle, and then we can easily identify the denubus fascia, the whitish membrane around the beginning of the seminal vesicle level. And this dissection is matched with the right side of the pelvic MRI and the sagittal coronal views. So I divided this area, the dissection between the mesorectal fascia and the pelvic floor, and then make a avascular space, rectum pushed medially, and try to, this is the denubus fascia here, and the pelvic floor, and the rectal wall. Okay, this is process from the rectal wall and mesorectal fascia completely separate from the underlying pelvic floor. This is lateral attachment here. So we can easily, gently approach the lateral part of the rectum. Is safely release the lateral rectal wall from the pelvic plexus. This is schematic drawing of the gate approach. Yellow area is a mesorectum, light pink area the pelvic floor muscles, and red dotted line indicate our dissection plan here. This is the denubus fascia and seminal vesicle here. And narrow deep pelvis, excessive traction of the rectum usually result in the avulsional injury to the pelvic plexus and the high risk of breaching of the mesorectal fascia, which means the incomplete TME. The dissection of the lateral attachment can be performed gently, so the mesorectum is separate from the pelvic plexus. as you can see, this pelvic plexus here. Let me show this photo after complete mobilization of the rectum from the pelvic plexus and neurovascular bundle, and pelvic floor posteriorly clearly seen, examiner vesicle and DBF, neurovascular bundle, and occasionally mid-rectal artery was present at 20 and 40% of patients. It can be controlled by electrocautery or clipped. Let me show another laparoscope video clips for gait approach. As I mentioned earlier, after I met the denubius fascia and seminal vesicle, and at this level I try to make a space through the avascular plane, and the mesorectal fascia and rectal wall separate from the underlying pelvic floor. As you can see, here, rectum is pushed medially. This plane is usually understood by coronal view of the MRI rectum. You can see that the anterolateral type of mid-rectal artery and lateral attachment here. Through the gait approach, we can easily, gently separate from rectal wall from the pelvic plexus by releasing lateral attachment, and mid-rectal artery clearly identified, and then in this case I divide it by clipping. And then I can safely separating from the rectal wall from the underlying pelvic floor and the lateral pelvic wall. Once again, a laparoscope gait approach, we can get a mid-rectal artery, and this was an anterolateral type of mid-rectal artery, and lateral attachment here. Micro CT for cadaveric specimen, a sagittal view showed in the DBF and right side. A DBF present between the rectum and seminal vesicle and prostate. For anterior pelvic dissection, you must understand the morphology of the DBF. Let me review the couple of points about DBF. First of all, DBF is not adhered to the rectal wall at the seminal vesicle level. However, DBF attached to the prostate, adhered to the prostate more severely. The aprion shape, and it descends to the perineal body. Let me talk about the important point, which is already well known. Neurovascular bundle to the genitalia is a very crucial structure for sexual function. A red dotted line means a dissection plane, which is posterior to the denubius fascia at the seminal vesicle level and the prostate levels. Neurovascular bundle covered by DBF and located at the 10 or 2 o'clock direction at the seminal vesicle and prostate gland level. Here show the well prepared neurovascular bundle here. Therefore, I believe unless anteriorly located advanced rectal cancer, anterior pelvic dissection should be maintained posterior to the DBF. This is a standard anterior pelvic dissection, just the posterior to the DBF. It's a major rectum, and this is seminal vesicle, and I grabbed the DBF. The dissection just the posterior to the DBF is the way to preserve the neurovascular bundle very safely. Yeah, you can see the pelvic floor. Long segment of anterior rectal cancer, clinical history from seminal-vesical to prostate level, anterior to the denubus fascia dissection beyond the prostate level is a necessary. Like this one, this is a red dotted line is a dissection to the anterior to the denubus fascia to avoid the positive CRM. However, at the tumor is only anteriorly located at prostate level. Initially, the dissection posterior to the denubus fascia at the seminal-vesical level. However, at the prostate level, dissection to the anterior to the denubus fascia is necessary. So we call it a tailored DBF excision according to tumor location and the depth of invasion should be considered. This is anterior located advanced rectal cancer at the prostate gland level, so tailored DBF excision was shown. Initially, anterior dissection starting the posterior to the denubus fascia. However, at the prostate level, the dissection and the switch to the anterior to the denubus fascia because the tumor was located at prostate level and very close to the prostate capsule. So I'd like to name that this is concept of the tailored DBF excision according to tumor location and the depth of invasion. You should be tailored excision of the DBF. Let me introduce the essential 7 steps for optimal rectal mobilization. This is article accept and this year disease in colorectum. I think this is 7 steps approach is the most safe approach for preserving the nerve and to get optimal TM specimen. First of all, incision of the pelvic peritoneum, initially posterior dissection and anterior dissection, deep posterior dissection this step we divide the widest fascias, and deep anterolateral dissection, usually in the gate approach, and deep posterolateral dissection. And lastly, we identify the pelvic floor. In summary, based on my point of view, 7 essential steps approach should be kept in mind, and gate approach and customized DBF excision concept to have a complete TME specimen and preserve adjacent nerve structures. Subsequently, lateral attachment can be easily exposed and gently divided, and sometimes we can easily control the middle rectal artery. I'd like to appreciate to all attendants for kind invitation, and also thanks to Mr. Chairman and also all members of Latin American Coloproctology. Thank you very much. Gracias.
Thank you, Dr. Kim, for your presentation. We're going to do the 3 presentations, and after that, we will discuss all the subjects together. Bien. Seguimos entonces con Jorge.
¿Quieres que ponga el share screen?
Dale, deberías estar habilitado, así que.
Ok. Ok, ¿pueden ver las diapositivas?
Se ve perfecto.
Ok, perfecto. Bueno, primero de todo, agradecer al comité organizador de la invitación a presentar. La verdad es que estoy muy agradecido de la posibilidad que me han dado de presentar con estos ponentes que tenemos, como el doctor Kim, el doctor Matthew Albert, además que el doctor Moreira y vuestra ayuda para entender un poquito más la cirugía, los abordajes quirúrgicos a la cirugía de cáncer de recto. Mi tópico era de cirugía robótica y básicamente empezar a discutir un poco que cirugía robótica ha sido una evolución natural de la cirugía laparoscópica. Una vez que hemos entrado en esta época en que tenemos la posibilidad de hacer una cirugía más ergonómica con el robot, que es mejor en teoría para el paciente y el cirujano, especialmente el abordaje de la pelvis en el varón, ha aumentado el uso de robótica, especialmente en cirugías de un cuadrante único, pero con las plataformas estas nuevas que tenemos ahora, como el XI, el XI, podemos hacer también abordaje en diferentes cuadrantes. Mirando, este es el número de publicaciones que han aparecido en los últimos 20 años de cirugía robótica en una MedSearch. Se ven que el año 2021 no hemos llegado todavía al final del año y el número de publicaciones son como 250 anuales, por lo que hay mucho interés en cirugía robótica, pero desde mi punto de vista hay que tener mucho cuidado con los resultados que se publican, porque veo en las publicaciones que hay mucho sesgo, hay muchas publicaciones que la tendencia de decir que, bueno, la visualización tridimensional es mejor, que hay mejor control y destreza y que hay menor conversión, estancia hospitalaria y menos complicaciones. Y lo otro que es, por lo menos aquí en Estados Unidos, es importante, es oportunidad de ofrecer una cirugía diferente para satisfacer la demanda del paciente con cirugía mínimamente invasiva. Aunque yo hago la mayoría de mis cirugías robóticas, mis recomendaciones es que cada uno tiene que representar con el tipo de cirugía que estás cómodo. Igualmente, viendo una cirugía laparoscópica del doctor Kim, esa cirugía que ha hecho él y ese vídeo que tiene, realmente una cirugía robótica que puedo hacer yo no va a eclipsar o va a disminuirle a él el hecho de que él que haga una cirugía laparoscópica perfectamente bien. O sea, yo pienso que cada cirujano tiene que escoger su tipo de armamento y en el que se encuentre cómodo de hacerlo. Con una experiencia total ahora mismo de 1.200 cirugías robóticas que hemos hecho en nuestra unidad, la mayoría de cánceres de recto los abordamos de tipo robótico, pero si no tenemos en ese momento availabilidad de hacerlo con el robot, entonces lo hacemos laparoscópicamente o hand assisted. Lo más importante que el paciente pregunta siempre es: voy a tener un ano contra natura, voy a acabar con una cirugía con una colostomía permanente. Desde el punto de vista de cirugía robótica, nuestro punto de vista y para hablar con el paciente es, lo primero de todo, tenemos que hablar de que hay que controlar el cáncer, o sea, que es una cirugía oncológica, no hay que pensar en el ano contra natura, en la colostomía permanente o no, con preservación de los nervios, que el doctor Kim ha hablado al respecto y ha demostrado con unos vídeos fenomenales de cirugía laparoscópica. Lo otro que es importante es disminuir el fallo de sutura, y en esto es donde pienso yo que cirugía robótica, especialmente con el uso de inmunofluorescencia, nos puede ayudar también. El hecho de evitar o no evitar ano contra natura y perfeccionar la técnica de pull-through, TATME, como se haya hecho laparoscópico o robótico, realmente todo depende de la mano del cirujano y la experiencia del cirujano. Pero lo más importante, yo pienso que es ofrecer un tratamiento mínimamente invasivo a los pacientes. ¿Qué abordaje es el mejor? Yo pienso lo que he dicho. El abordaje, yo pienso que depende del cirujano. Hay cirujanos que se encuentran muy cómodos de un laparoscópico, hay cirujanos que se encuentran muy cómodos de un robótico. Porque realmente cuando haces una visión retrospectiva o unos análisis de todos los abordajes quirúrgicos, realmente no hace diferencia. Lo que hay diferencia es el número de cirugías de cáncer que tú haces y qué importante es. puesto más que nada el estudio de Roller, que fue hecho hace muchos años, en el que desde mi punto de vista el design flaw fue decir que cirugía laparoscópica en aquel entonces había una conversión del 25%. Cuando ves números como el doctor Kim, que tiene una conversión del 1, 2, 3%, realmente el diseño de este estudio tiene un flaw significant en el que no se puede acabar con datos concluyentes. Pero cuando miras el subgrupo de análisis que hubo, hay una conversión que es menor, y esto parece que es una cosa que se repite en muchos de los estudios que he visto, incluso en los últimos de este año que han salido, en el que la conversión parece ser menor. Eso fue uno de los primeros estudios que publicamos en Annals in Surgical Oncology con varios de mis coautores, en el que nosotros notamos que había una conversión menor en pacientes, incluso en pacientes que eran relativamente obesos, con una BMI de más de 30 kilos por square meter. En este estudio, en el que hicieron un análisis sistemático y un review en el que compararon resultados entre cirugía robótica y laparoscópica, realmente no hubo diferencia, lo cual más llama la atención el hecho de que es, como he dicho, es el cirujano que hace la cirugía y el robot es básicamente un tool que es el que vas a usar para hacer esto. Lo que sí notaron es que la conversión en este análisis era menor en cirugía robótica. Pero cuando miras otro dato, por ejemplo, este es el dato anatomopatológico que el grupo de Marilyn Boutros, que es una exalumna nuestra del Cleveland Clinic, que había publicaron que cirugía robótica realmente había una conversión más baja, pero la tasa de margen de resección circunferencial positiva era similar entre los grupos de abierta, laparoscópico y robótico. Otro análisis en el que hicieron una revisión sistemática, este es un análisis japonés, que hicieron un análisis interesante usando lo que se llama el AMSTAR Tool, que es para comparación de los estudios. Concluyeron que no hacía una asistencia, que no existía una evidencia muy clara, pero era de calidad baja, al respecto de que cirugía robótica disminuye la incidencia de conversión en comparación con la cirugía laparoscópica. Es interesante ver aquí en Estados Unidos, con la disparidad médica que hay entre el sistema social. En el grupo de Randy Steinhagen publicaron en el estudio después de analizar el National Cancer Database, en que realmente había una tasa mayor de uso robótica, especialmente en varones que tenían un seguro privado y que tenían un estadio 3, que vivían a unas 25 millas del hospital y como mínimo tenían un nivel de educación. En la conclusión que tenían, decían que había un uso menor en personas de un nivel social más bajo, por lo que concluir que cirugía robótica se aplicaba a cualquier persona realmente no era apropiado, que es lo que muchos de los estudios han dicho. Cuando se habla también de comparaciones, este grupo italiano compararon usando un average treatment effect, la cirugía laparoscópica con la cirugía robótica, y la conclusión que hicieron cuando aplicaron el término estadístico fue que la cirugía robótica debe tener una conversión menor. Cuando miras al grupo de Mayo Clinic con David Larson y Scott Kelly, lo más importante, y una de las cosas que el doctor Kim había presentado que era importante, era ver la zona anterior del recto, que es la zona más importante en la que puede haber una mayor tasa de riesgo de margen circunferencial. El grupo de Mayo indicó que usando una Fleet Regression Logistic Model, que pacientes con una T3, con una extensión de más de 5 milímetros anteriormente, estaban a riesgo de un margen positivo circunferencial. En este tipo de paciente, yo pienso que es importante poder usar cirugía robótica para acceder a esta zona deep en la pelvis. Otra vez, otro estudio publicado recientemente del grupo de Mayo Clinic, con más de 600 pacientes analizados, 317 robóticos. Lo más importante de ellos es que cirugía robótica tenía menos complicaciones, casi la mitad menos, con un factor de protección cuando analizaron el odds ratio bastante menor en comparación con cirugía laparoscópica o conversión a laparotomía. Desde mi punto de vista, con la experiencia nuestra que tenemos en el hospital, las claves del éxito en cirugía de cáncer de recto son las siguientes. Lo primero de todo es, en el robot nuestro que usamos el XI, es estandarizar todo lo que hacemos. Tenemos la misma cámara, tenemos las tijeras o el gancho con el electrocautery, tenemos el mismo vessel sealer, usamos todo igual. Cualquiera de los 3 cirujanos que tenemos en la división mía, usamos todo en cualquier cirugía. O sea que estandarización es importante porque entonces el grupo de enfermería que estás contigo en el quirófano te pueden ayudar bastante mejor. Lo siguiente es la posición de los trócares. Esta es la posición nuestra que hacemos estándar para acceder, incluyendo el acceso al ángulo esplénico si tenemos que hacerlo. Y normalmente ponemos un port de 5 milímetros o ponemos uno de 10 en el right upper quadrant para el asistente. Esta es la posición del robot y entrada lateral en la que hacemos para hacer cirugía. Y lo más importante es tener una coreografía que el doctor Kim ha mencionado también en cómo acceder y cómo ver las estructuras vitales. Lo primero, identificación de los vasos sanguíneos, de los uréteres, identificación de la patología, la localización de este tumor, especialmente con una regresión importante en pacientes que han ido a través de quimio o radioterapia, de los que hay el tumor ha disminuido significativamente. Mantener la movilización, la resección, la anastomosis en el mismo plano y asegurarnos que estamos siempre en el plano del toro mesorectum. Y en nuestra experiencia, cualquier resección con menos de 5 centímetros del ano o que han sufrido quimioterapia y radioterapia tienen una ileostomía de protección. Hablando un poquito con la coreografía, básicamente empezamos en el medio lateral, pero a veces si tengo un residente me es más fácil para mí identificar el uréter lateral y medial y dejarle al residente que practique la entrada en el medio lateral. Identificación de la arteria mesentérica inferior, del uréter, básicamente la disección de la línea de Tolt. Personalmente accedo presacral hasta los levators y después hago la disección lateral y anterior, un poquito diferente al Dr. Kim, pero identifico el de non-Villiers también para asegurarme que hacemos una preservación de los nervios. Viendo un vídeo, esta es la zona de acceso y normalmente voy en este surco que hay aquí para entrar en el espacio presaco. ¿Veis los vídeos bien?
Sí, se ve muy bien.
Los vídeos, ¿no?
Sí, se ve perfecto. Sí, se ve bárbaro.
En esto es la identificación del uréter. No me gusta, a mí no me gusta usar la tijera mucho, pero ya podéis ver que el uréter está ahí con peristalsis. Identificación del pedículo vascular. Aquí en Estados Unidos y como en todo hospital es importante el gasto. El uso del vessel sealer puede ser tan alto como $580 o $600 por uso. Y en muchos de los vídeos que se pueden ver, dependiendo de quién es el cirujano, se usan mucho los Hemolo clips, que cuestan $58 por uso. Una vez que hemos visto el espacio presacral, este vídeo no sé por qué no está funcionando, pero en teoría tiene que salir. Vamos presacralmente y no sé por qué los vídeos no salen, porque han estado saliendo hasta hace 5 minutos en show. A ver si lo puedo enseñar así. La verdad es que no sé por qué no están saliendo los vídeos ahora mismo. Ok. No. Bueno, tengo problemas ahora mismo con el vídeo, no sé por qué está pasando esto, pero no me está saliendo. Uno de lo que hacemos una vez que hemos hecho el abordaje presacal es mirar, que hemos usado mucho, es el uso de inmunofluorescencia en una anastomosis intracorpórea, en el que básicamente ponemos el immunofluorescence y después de 10 miligramos de ICG vemos la anastomosis. Yo pienso que esto es importante para nosotros a la hora de hacer la anastomosis colonal, en la que vemos la anastomosis completamente con una perfusión, y pienso que disminuye el riesgo, por lo menos el cirujano está más seguro de que ha visto la anastomosis. Una cosa que ha facilitado mucho la disección en la pelvis en profunda ha sido el uso de la grapadora robótica, que pienso que nos ha ayudado muchísimo para hacer la resección a la altura de los ligators, de los elevadores del ano. Como pueden ver, la grapadora te da mucho feedback de qué es lo que está pasando y si la grapadora es completa o no completa. Y una vez que vemos que la grapadora ha aguantado y la compresión es completa, entonces puedes hacer el firing y completar la transección del recto en la pelvis. Una vez que hemos hecho la transección distal, la tendencia mía, esto es uno de los ports, con uno de los abordajes antiguos con el SI. Normalmente saco el recto a través de la ileostomía, y lo que hago normalmente es un colgajo de piel en vez de usar un tubo de plástico, y uso la piel del paciente, por lo que no tenemos que traerlo de vuelta a que le tengan que remover el tubo de plástico o mandar a una enfermera a su casa. Este es un ejemplo de una anastomosis ultra baja a nivel de elevators, con la ayuda del robot. Y como ha dicho el doctor Kim, lo más importante es evaluar la calidad del mesorrecto, en el que está con dos bellows que son completos, y el tumor distal con los márgenes distales. Esto es un ejemplo de una combinación muy similar al TATME, pero esto es una disección ultra baja. Es el vídeo, funciona ahora, en el que hemos hecho la disección completamente robótica a través del abdomen, y ahora mismo estamos haciendo un TATME en el que extraemos el recto. Una de las cosas más importantes al respecto de hacer cirugía robótica es tener un equipo que puede responder rápido a los problemas. Y esto es un problema que, aunque pasa raramente, no sale. Estoy intentando play el vídeo, pero no me está saliendo. Básicamente hay una injury al inferior mesenteric artery, a la arteria mesentérica inferior, en el que ponemos básicamente dos clips con la ayuda de los asistentes rápidos, en el que cambian el gancho, y podemos hacer el control vascular. Cuando se mira la literatura, la publicación que hay es básicamente indica que cirugía robótica tiene una curva menor de aprendizaje. Estos son los primeros 60 cirugías robóticas que hicimos nosotros en cáncer de recto, en el que se ve que la curva, la disminución del tiempo es muy progresivo al principio, y una vez que se llega a una zona plana, estamos aquí. Muchas de las diferencias grandes que hay en las cirugías finales después de 60 se atribuyen también a los residentes, porque tener un residente, llevar un residente a través de una cirugía robótica, normalmente añade como 60 minutos en la cirugía. Estos son los resultados nuestros de 5 años desde el 2011 al 2015, en el que tuvimos una recurrencia loco regional de un 3%, el 92% sin recurrencia y enfermedad metastática del 5%. Estos son datos del 2011 al 2015 que reportamos al Cancer Committee. Lo otro que es importante para el hospital es el coste en cirugía robótica. Y esto es la progresión nuestra desde 2011 al 2015. Y estamos en medio de obtener los resultados ahora del 2015 al 2020, en el que hemos añadido también el XI, porque esto era con el sistema SI. Y los datos, una vez que llega, yo pienso que estaremos casi en el mismo coste que en cirugía laparoscópica. En conclusión, la cirugía robótica de cáncer recto debe ser considerada en el armamentario del cirujano para cualquier cirugía de pelvis profunda. Y la técnica, pienso que es importante, el cirujano tiene que estar cómodo con esta técnica. Si realmente no estás cómodo con el robot, hacer con el robot no es una buena idea. Y los datos sugieren ahora mismo que hay una conversión menor y con el coste menor de las complicaciones. Muchas gracias por la invitación, aunque ahora mismo este año el Barça no está muy bien porque hemos perdido a Messi. A ver cómo acabamos la liga este año, pero de todos modos quería agradecer a todo el mundo en Latinoamérica por esta invitación, y están más que invitados de venir a visitar el Charleston aquí en Carolina del Sur. Gracias.
Muchas gracias, Jorge, por tu presentación.
There you go.
Bien. Matthew, ¿estás? Matthew, are you here? Hoy lo teníamos también.
Yep,
Antonio.
estoy aquí.
Ah, aquí estás. Okay.
That is the only Spanish-speaking South Carolinian in the entire state.
No, they have Margarita Murphy also in South Carolina.
Oh yeah, Margarita's in Italy right now. That's probably why.
Solo dos, los ambos. Yeah.
Right.
All right, let me hit share. And Microsoft Power. Okay. Here we go. All right, thanks, Alejandro, for the invitation. I'm going to talk about TATME. I am sitting in the post-op recovery room here, hiding from the nurses. This is the hospital, Florida. Sorry, not Florida Hospital. Used to be. It's Advent Health in Orlando. Alejandro, you visited. A lot of your other colleagues are. This is a picture of the Dragon capsule last week with these all civilian astronauts. Pretty cool. Goes right over the hospital. I have the following disclosures. So what was the goal of all this from TATME? The goal was to probably improve MIS delivery with less collateral damage, better visualization and ergonomics that we've been dealing with laparoscopy, minimize conversions, and maximize sphincter preservation. I think like many other countries, and I think unlike many Swedish and Scandinavian countries, patients in the United States place a very high burden on avoiding stomas. Sorry, just had to move. And so Everybody can do this. All your residents you teach to do this. The upper rectum finding this TME plane is absolutely, is generally pretty simple. The only structures to avoid are the hypogastric trunks in the midline when we start, but this is all pretty easy. On the other hand, it's this last 10 centimeters of extraperitoneal rectum that poses the big challenge. Increase CRM positivity, increase conversions to open, which, by the way, often don't help you. You realize it's just as much of a struggle. And so rectal surgery in the obese was the impetus behind our strategy here. This started kind of completely spontaneously and organically in the operating room with a patient who we were unable to proceed. And so this is a fairly heavy patient, BMI 32. Which is pretty light here. But, you know, down when you get to the peritoneal reflection, it's a constant struggle of retraction, changing over. And this is what makes laparoscopy hard. Poor instrumentation, non-ergonomic. You know, some people do this from both sides. I try to do it all from just the right side of the patient with my assistant. But that's slow going to get past the prostate. It's amazing how the last 10 centimeters takes 2 hours and 80% of the case. On the other hand, this is the same patient from the transanal approach that you can see. I start anteriorly every time. I find that the easiest landmark, and I find it to be an early, unbelievable victory of identifying the anterior structures that are often so hard to dissect. And so this is just sped up a tiny bit, but literally if I wanted to, I can do this entire anterior dissection, get into the peritoneal cavity in all of maybe 5 minutes. On the other hand, we don't like to go consistently anterior, as a lot of you know that we do this circumferentially, but in this one with some editing, you see how quickly you can get up, perfect prostatic dissection, decide where you want to go on top of the non-VAs or inferior to the non-VAs, and easy to get anterior. Probably the easiest part of the dissection when we talk about TATME. This is a robotic case I did. I think my disclaimer is I do robotic surgery. I do laparoscopic surgery, open surgery, hand-assisted surgery, however I can do it that works for the patient. And this is one of the frustrations, even with the robot now. This is the non-robotic stapler that we use for it. I would not say that the ergonomics of the robotic stapler are so massively better than what you get with laparoscopy. You have the same challenges, the same reticulating scopes. And after all that dissection, you now have this poorly transected rectal stump with that nice big dog ear. Luckily, some tricks that you see, you pull that in and you can see that this endoside anastomosis is not so bad, but it's a disheartening feeling when you get to that. The distal margin, again, I've seen where we work for hours and hours and hours only to sit and deliberate over where the distal margin is. Over the last couple of weeks, I've had this rash of massive tattooing of the entire mesorectum. That doesn't help. There's no palpable sense to know where these are. And we've all probably experienced, except I'd probably say maybe the Korean surgeon has it. In the United States, we've all seen the patient with an early tumor that had a positive margin in the staple line or basically stapled right through it. And that always yields a terrible outcome. So for me, this is one of the hallmark signatures of this. You can see this FAP patient on the right side. In this one, if you look closely, that I'm even being very careful on my bites, that I'm just taking a submucosal stitch. You don't want to catch the levator muscle this far down. But this is a FAP patient with a cancer as well. And you can see how nicely that you can define the distal margin without distal to all the polyps. And in fact, again, when you see the fact that I am taking just a submucosal bites here and not full thickness bites, it allows that when you tighten this up, that you will see the anal canal slide up even further. And so now I really have a good margin to do basically a mucosectomy almost through the channel there. On the other hand, this is a rectal cancer, low rectal cancer, status post total neoadjuvant therapy. You can see some of the scar here. I think out of our series of about 200 patients now, we did have one positive margin microscopically and that patient actually had repeat surgery completion APR with a negative specimen at the end. Now, you see no purse ring here. It's a bit too low. In this one, we did keep an open lumen and then closed it all prior to proceeding. In my preference, I think we should always be closing the lumen. Then again, when you look at John Mark's experience with Tata for 25, 30 years now, that it's always started with an open lumen. As soon as he dissects a little bit, then he closes it, rinses it out with beta-9. This patient's 6 years out, so I can tell you this was safe and she's has no local recurrence. Sphincter preservation. United States, some literature 10 years ago demonstrated 60% of general surgeons only do abdominal perineal resection. This was in Annals of Surgery from the French group. Lots of experience in sphincter preservation, intersphincteric, partial intersphincteric, full intersphincteric resection. But this was their study, 8-year experience, decreasing APR rates to nearly 10%. In this study, it was a combination of local excision following treatment plus or minus intersphincteric resection. And in fact, these days, this is the only contraindication to sphincter preservation, invasion into the external sphincter muscle. And even that, I can say I've reviewed a paper recently from either Japan or Korea, where they even did partial external sphincter resection as well. So perhaps that's not even a limitation anymore. Perhaps there's an oncological benefit. This was our thought early on, certainly from the latest colorectal rectal cancer studies that Dr. Kim just showed. The color 2 certainly wasn't phenomenal outcomes, a CRM positivity of 9%, 22% in open, compared to, this is the perineal approach, once again, by the Quentin Denos, the French group, that showed in their series of perineal approach, only 4% CRM. The United States audit most recently demonstrated a 17% CRM positive rate for the entire all comers in the United States. So we have room to improve for sure. I'm not sure where that came from.
Okay, I'm in.
Again, sphincter preservation, this is exteriorized, that's the marginal. We do use ICG for all of these. And this is showing, again, the level of the pelvic floor and anastomosis. Unlike from above, we don't dissect past the rectum or anal canal. Unlike you have to do in every other way, you have to over-mobilize past it so you can deliver a stapler in there, whereas this may be a result of some increased, perhaps, blood supply to the anorectal stump. Margin positivity, CRM, all looked real good in all the initial small volume series. We see still holding this to be true. Distal margins almost always negative given our ways. Nerve preservation, perhaps, again, we thought maybe given the increased visualization. The French, once again, published their randomized study, 100 patients, lap versus transanal, and demonstrate some improved sexual functional outcomes in the transanal group. And then you go conversions. Laparoscopy is still really hard. And this study demonstrates the real challenge, as always, which was an overall conversion rate of 15%. Intraocular fixation and male sex, always the culprit, in addition to morbid obesity. But you could go back to the classic trial where there was a 30% risk of conversions. In that study, they said we didn't have the right surgeons. They didn't have as much experience. We reproduced this years later. If you look at the Rolar study, where it did not significantly reduce conversion to open laparotomy. Interestingly, editorial on this said, once again, we just didn't have the right surgeons doing this, a common theme in all of these studies. But on the other hand, with transanal surgery, there really is virtually minimal to no conversion rates. The French study had 4% 2 patients, but we've never found a need to convert in a series over 200. And synchronous surgery, perhaps done early on to be very sexy. It certainly enhanced the attraction of this technique to many around the world. No doubt that if done correctly, properly, and with some work and experience, this could be done, you know, real nicely. It's often done sharing that sometimes there's exposure from the up above team, like in this case, sometimes it's the opposite, and then sometimes, in fact, both are working. But it really allows improved retraction and improved facilitation for the assistant. Instead of retracting from above, you're just retracting from below. More recent one, again, you can see such that perfect prostatic view. You can see the team from above isn't doing so much here except exposing for us, keeping the rectum off the sidewall there. But this view right here, I don't think that you can get this in anything else except perhaps robotics, with how close the camera is, with how easy the retraction is. And I think the view remains superior to certainly laparoscopy, without doubt. Won't go crazy over all the data from this because you know and seen the majority of it. Lots have looked intently. This was all from our database early on. The registry collected over 3,000 patients, where you see even amongst random surgeons sending these in, that intact TME specimens were very high, grade 2 and 3, 85% of the time, with very low CRM positivity rate. Our group 2 looked at case matched of our robotic transanal TME along with Dr. Kim from Korea using his robotic data, and Dr. Lacey using his TA-TME data. Really no difference in outcomes, complications, or anything else. So quickly, here's a more recent video. As you know, one of the key principles of this, and perhaps the most critical, is the purse string. This is also the step which almost all surgeons have the most challenging time with. Despite laparoscopy, unlike bariatrics, colorectal surgeons never hugely develop their suturing skills. Even with TAMIS, we often taught this with alternative suture devices. But over the last 5 years, this has all been a really good excuse to enhance your suturing skills. So there's no doubt these are better done endoscopically stitching it. It can be done in an open fashion. The next step, we mark this out. And you can see these subtle just changes right here. There's no question I'm a bit too close on this margin. I should have gone back. The ultimate final margin on this was negative. But once again, you can see that the anterior plane is one of the easiest. As that longitudinal muscle is divided right there, the entire plane opens up. And here, just finishing off the muscular division of the rectal wall. Even if one only gets to this part right here, I think they've already improved their chances of getting a complete resection and being able to perform anastomosis. No longer am I, as our group, really going and seeing, let's see how far up we can go or do this all transanally. These cases are done all with fellows. So we go from above, we mobilize the colon, we go as far as we can below from above safely and easily where it's simple. And at that point, we convert to a transanal approach. So you'll see in this patient that we don't even dissect up that far to do it from below. But the critical part is we've defined the margin. We've done the last 8 to 10 centimeters of the rectum really nicely and intact, and it allows us to do an easy anastomosis. Again, you can see coming off the anterior quadrants here where the inferior plexuses are, difficult part of the anatomy, but once enter the peritoneal reflection, you can see fairly easy to complete these operations. So why are we even still arguing about all this? Well, lots of people jumped on board. probably lower volume, although we did our best efforts to teach the right surgeons that had a high volume, good technical experience. It's certainly hard to police the entire world. And there were certainly some bad, unique complications that came along with this. CO2 embolism, you can see here, almost certainly related to a tangential vein injury. If you look closely, that's air coming out of the venous system right there. We published this in DCR. We had 25 of these internationally and worldwide that we collected. There were no deaths. I think the entire key concept with this is knowing about it and allowing your anesthesia team to know and expect it. And that solves lots and lots of problems when you know about this potential complication, that you know how to quickly eradicate it. We all saw the TME moratorium in Norway with increased multifocal local recurrence up to 7%. And yet the more recent publications from the Canadian Collaborative, with more than 300 cases, demonstrated local recurrence rates of just 3 or 4%. And then lastly, the dreaded urethral injury. This was something we picked up early on in our experience. We spent lots of time teaching surgeons to avoid this. Pat Silla led a project on this, looking to see and I think published about 25 urethral injuries. These are bad things that happen because urologic reconstruction is often necessary afterwards. But I think this is very avoidable as well. And then lastly, one other theme as far as the local recurrence and everything else is, in my estimation, this is no doubt related to transanal insufflation of an open lumen of rectum with live tumor cells. And so those of us who do this still, I think a lot of us have modified this technique just a little bit, with the modification being, once we have divided the rectal wall, the rectal stump is closed again. We try to imbricate this somewhat so you can take the muscle wall surrounding it. We use just a running V-lock. This can be easily done endoscopically. But now, even with retraction moving around, that you know that this is probably sealed as well or better than your endo-GIA that puts 2 staple lines down. So we always routinely do this to avoid purse string failure, leakage of tumor cells. I am sure that we can safely say that we can hypothesize that that is the cause of these local recurrences. And lastly, I think the real hidden benefit in these techniques is for revisional surgery and failed rectal cancer surgery. One of the toughest things in the past, dealing with these sinuses and chronic leaks are problematic. This is an interesting one. An obliterated anastomosis. This was a leak that was referred in, tried to be diverted and repaired. And 3 months later, you have the obliterated anastomosis. This is fantastic because you already have the closed rectum lumen. And so anyone who's done these from above knows that this is a combination, usually probably some ischemia, some sepsis, chronic anastomotic sepsis. And then it becomes very difficult from above to think that you're going to get past the disease and put a stapler below the disease is just faulty thinking. On the other hand, that within 10 minutes of the operation, I can have a perfect anorectal cuff that I know is amenable to an anastomosis. So you can see what happened from above. This is the vagina, which is completely socked down anteriorly to this septic response. So from above, getting the vagina off is near impossible. On the other hand, again, we go right into native healthy tissue, transect the distal rectum, take out the disease part, and you often are good to go to bring down a new conduit. You can see this was nothing flashy. I even needed a hand in there to help extract this thing and widen it for a conduit to come down. And lastly, another patient, I found that we can often go and just remobilize the colon laparoscopically. Sometimes it's a little stuck, sometimes a little more, but this is all being now remobilized. I find that you need still need a good conduit. We then free this up, and generally you can dissect out your conduit and maintain its integrity in the marginal all the way down to the septic process. And then we abort and go down below. You can see this anastomosis wasn't too healthy, but within 10 minutes, once again, I have a new anal rectal cuff to suture to without the need for a stapler. I can use an EEA if I want at the end of this, but there you go. We divide the rectal wall here, and in minutes, you have a new distal rectal cuff. And again, you can see the inflammatory septic response. That is challenging to get above without the anastomosis falling apart, get to distal native rectum and put a stapler across it. It just doesn't happen. We actually get a good number of referrals for these patients now for revisions. And even locally advanced tumors, this is into the seminal vesicle here. Robotic surgery, I think, is a fantastic approach to this, because being able to come through the seminal vesicles and then land back on the distal rectum in the correct plane is, again, very challenging. So in this case, we've exposed the right vesicle here. It comes along, it's too difficult. So we head transanally. You can see that we come all the way around. We leave that anterior portion. And now it becomes very easy when you switch back up to the top here. I take out the vas on the left side that's entering the seminal vesicle. And then now you can see we've dissected past that. You can put an instrument in there so you can tell that you're on the other side of all this down in the pelvis. And again, you've already divided the rectal stump on the other side. So finally, you can final blows. That makes it very easy to just transect the seminal vesicle and the specimen comes out. So I think at the end of the day, we all have the exact same goal for these. It is macroscopic, good resection, negative CRM, sphincter preservation, MIS perfect, try to maintain all function. I think in delving into some of the problems of TA-TME, look, at the end of the day, these are all the same oncologic principles that we all do, just in a different fashion. Bad rectal cancer with a grade 1 specimen, incorrect plane. We've always known rectal perforations, that leads to bad outcome. So TA-TME can be performed with adhering to all these principles, but we know it's difficult with a high learning curve and unique complication profile. So I think it's very safe to surmise with that given these oncologic concerns of local recurrence, this is from, unfortunately, lower volume or poorly trained surgeons early in their learning curve, breaching some of these principles, having an open rectum with tumor cells flying everywhere. It's not rocket science, all right? Because we have large series with good local control and equivalent outcomes. I think that it does have significant advantages in the super user and the expert who knows how to do this. I think with high volume, there's safe implementation, but no matter what, the objectives are the same. If you're going to do this, you have to do any of these safely and oncologically sound. Thank you.
Thank you, Matthew, for your great presentation. Y aquí lo tenemos al doctor Guillén. Muchas gracias por conectarse, que nos quería compartir un video y después empezamos con la discusión con Luis y todos los que quieran participar y los panelistas.
Muy bien,
José,
gracias.
adelante.
¿Me pueden
Bienvenido.
oír? Gracias.
Estuve
un poquito tarde porque tuve un caso, una emergencia con un ginecólogo, entonces les voy a presentar el video. Son 10 minutos de un video que fui invitado a presentarle en la Sociedad de Cirujanos Americanos recientemente, esta primavera. Voy a hacer el share screen y lo voy a dejar que la presentación son 10 minutos completo, entonces le voy a dejar que la presentación comience ya. Me dice cuando la pueden ver. ¿La ven o no?
No, no sé. Ahí sí.
Ok.
key steps that are followed. We use the assistant on the right side with the tower and arms on the left. The camera is supraumbilically located, and 3 8mm ports are located, one in the right upper quadrant, 2 in the left lower quadrant, air sealed laterally, and a 12mm port in the right lower quadrant. This is a 55-year-old patient with distal rectal cancer, status post total neoadjuvant therapy. We begin by identification and ligation of the IMV. We are in the 12 degrees Trendelenburg and 12 degrees right lateral side. The assistant is keeping the small intestine laterally. We incise retroperitoneal sharply to prevent any welding of tissue, and gentle lift of the IMV facilitates retroperitoneal dissection sharply, both laterally, anteriorly, and superiorly, to develop a plane in an avascular fashion. The attachments are released sharply. Fat is cleared off the IMV in a circumferential fashion. It is important to dissect enough laterally to be able to resume further dissection once the vein has been transected. We use the vessel sealer with multiple applications. The leading edge is once again identified and retroperitoneal dissection continued laterally and inferiorly with the scissors, which facilitate sharp mobilization as well as cauterization. The IMV pedicle is grasped. Our attention is directed towards the right pelvic sidewall. The ureter is identified, and we begin a lateral to medial mobilization with the position now in 25 degrees Trendelenburg and 12 degrees right lateral side down. Gentle lifting of the structures facilitates identification of the ureter, the superior hypogastric plexus. Further dissection anteriorly identifies the IMA, and fat is cleared off of the IMA sharply by using areolar planes, as noted here, both inferiorly and superiorly to the IMA, as shown there. The ureter is mobilized laterally and retroperitoneally. The remaining fat is cleared, and the ureter is visualized both superiorly and inferiorly to the IMA. Remaining fatty tissue is cleared with the vessel sealer, and the IMA transected with multiple applications of the vessel sealer. Autonomic nerves have been preserved, and dissection continued laterally, preserving the ureter. Attention is mobilization of the left colon from lateral to medial, crossing over the left pelvic brim with gentle traction anteriorly and superiorly. The sigmoid is rendered a midline structure, and the lateral to medial dissection is merged with the medial components in a both cephalad and caudal manner. Spiniflexion mobilization is facilitated in the 12 to 12 degree position, anterior to gyrardus fascia. The attachments to the splenic flexure, including splenocholic, gastrocolic, and phrenocholic ligaments, are transected with the vessel sealer, as are any attachments to the omentum. This is continued medially to facilitate a tension-free anastomosis, including releasing of the stomach. Other helpful maneuvers include transection of the bay area medial to the marginal arteriodrumen, which facilitates significant mobilization as depicted both medially here and laterally. The lateral to medial retroperitoneal dissection continues. We're now back in 25 degrees Trendelenburg and 12 degrees right side down. The dissection continues in a retroperitoneal fashion, lateral to medially, preserving the left ureter. With full mobilization of the splenic flexure, sigmoid, colon, and left colon, The robot is repositioned and retargeted to the pelvis. The third arm is used to grasp the rectum. The IMA pedicle is grasped by the assistant, and the superior hypogastric plexus is identified and released with great usage of the third arm for traction. For this, we are 22 degrees to Nullenberg, 0 degrees right side down. The superior hypogastric plexus is further identified and preserved by incising an alveolar plane in a wishbone-like manner. This pelvic dissection continues in a circumferential manner. It is important to keep the horizon properly oriented and to use left over right crossover maneuvers to perform the left pelvic sidewall dissection while preserving the left ureter. The dissection continues in a circumferential fashion, taking advantage of the peritoneal reflection and usage of the third arm to lift the pelvic structures anteriorly. It is also used to grasp the colon to facilitate mobilization of the right hypogastric nerve deep into the pelvis. The nerve regentes are cropped to the right pelvic sidewall anterior to the superior hypogastric plexus and the piriformis muscle. This is quite a fenestratic structure as depicted here. And with traction, penetraction, and proper orientation, the hypogastric plexus is preserved while the fascia propria of the mesorectum remains intact. This dissection continues distally in a circumferential fashion, taking advantage of the peritoneal reflections as shown here, ultimately in a circumferential manner, releasing the remaining left anterior attachments with repositioning of the third arm. Gentle traction anteriorly and posteriorly facilitates visualization of thenumbular fascia. This is further incised, and the dissection continued in a circumferential manner. We're back in the right posterior quadrant, looking at the piriformis muscle, dropping the nerve argenti while preserving the fascia propria of the mesorectum intact. In some instances, a 1/4 inch vaginal packing is used for further tracting to facilitate preservation of the left seminal vesicle on the right pelvic sidewall. We are now in the left posterior quadrant, looking at the preservation of left nerve argentes, released to the piriformis muscle. The assistance from the bedside assistant is indispensable for visualization and traction, as shown here. The sucker used for traction and evacuation. The dissection continues now anteriorly, further incising the non-volus fascia. The pelvic floor is visualized in attachments at the level of the puborectal sling, released both on the left pelvic sidewall posteriorly shown here, anteriorly at the level of the muscular cuff, while preserving the rectal tube intact. In this patient, a female patient, we see the pelvic floor and we see the clearance of the fat around the rectal tube circumferentially, and full desacralization so as to allow a green stapler to transect the rectum at 90 degrees. With the proximal limb now positioned with the anvil, the 3-arm approach is used, and a bedside assistant using 2 arms to assure a tension-free, properly oriented anastomosis with full sacralization of the proximal limb. The anvil is delivered just off the midline of the staple line. And an end-to-end anastomosis created under direct visualization, taking great care to avoid any twisting, assuring that the mesentery faces to the right or to the back, that the small intestine are out of the way. And the bowel is not twisted. Following firing of the EEA stapler, the donuts are examined, and the integrity of the anastomosis is further confirmed using the tile probe maneuver for air insufflation and visualization of the pelvis, as well as the colonoscope simultaneously. Several key steps that are followed.
Disculpen, eso fue todo. Gracias.
Excelente, José. Muchas gracias por compartir.
Encantado, gracias.
Bueno, y ahora vamos a pasar a los comentarios. Vamos a empezar con el doctor Romagnolo, que lo tenemos como invitado experto, así que le damos su espacio para los comentarios y después vamos a ver algunas preguntas. Luis.
Gracias, Alejandro. First, how many have time to talk? 5 minutes, 2 minutes, 1 minute?
The time you want. The scheduled time is 10 minutes.
Okay. So first, it's amazing presentation for all. It's impressive how we can see the quality of the image. How can we change the possibilities to treat the patient? But one thing it's nice to talk, it's about Latin America possibilities. Here we have the most of the robot platforms are in Brazil. In other parts of Latin America, you don't have so many kind of robots. And so we have to think about laparoscopy and TATME, because there's a possibility to treat laparoscopy rectal using for rectal cancer. Laparoscopy could be only the possibility to treat the patient. One thing is when you have robots, I have robot here in my hospital, and we perform more than 80% of the rectal cancers. We use robots, but in possibility in public health system in Latin America or private, some countries in Argentina, Chile, Bolivia, we don't have so many kind of robots, just 1, 2, or 3. So this is one point that you have to talk. That is the reason that I believe that when we discuss about when we have distal rectal cancers, 5 centimeters to an verge, 4, 6 centimeters, the possibility to treat a combination using combination the laparoscopy and rectal approach, the distal approach using 2 teams could be a very nice possibility to treat the patient. But one thing it's important to discuss: how many cases do you have to do per year to be a good surgeon to perform this procedure? So the problem is there are some hospitals in Latin America that people that perform 1 rectal cancer per year, 2, maybe 10 per year, and they try to do a rectal procedure, transanal TME, and that they cannot do a good procedure. So this is another question to discuss. So we have very nice experts here to discuss. When Matthew talk about transanal TME, in his hands, everything is possible. Everything is possible. When Professor King talk about laparoscopy, everything's possible, because how many cases they perform per year? 10,000 cases. Here, maybe in specific centers, we can do this. So one thing that the idea, the aim of this discussion today is we need to train more. We need to discuss more how to train the people to become our residents, our fellows, or our professionals, and very nice. So this is the idea to discuss about this. Here, I believe that the first time that I did the robot, I didn't train. I use robots all the time, for right colectomy, for left colectomy, But for rectal cancer, I believe that it's a specific platform to do this. This is my consideration about this talks. Another point is using all the possibilities that we can have. ICG to you to see the quality of the column that you to perform the anastomosis. You have to do when you do transvenous TME, it's important to say that you have to have a very nice high insufflation system. You have to use gel point path because it's a very nice, I think that specific platform to do this procedure. And one thing it's important, you need to have a very nice camera guy with you to do to give to you a very nice image. So this is my considerations about this. And one thing, another word is it's important to say that the guys that's talking today, they are very experts, and it's amazing when we listen their experience and how to manage using this platform. If you remember the video that Professor King showed, he never used many traction to avoid the mesorectum. So the laparoscope procedure, the specimen, it's a very nice specimen. You don't see any break in any injury in the mesorectum. And you see Professor Gillen showing the video. It's amazing video how to dissect. And one question that I would ask for Jorge and Professor Gillen: when you do robot, are you doing lateral to medial or medial to lateral? Because after when I started, I using robots, now I'm changed and I'm doing lateral to medial for me, and I attack the artery first, not vein first. This is my position. So once again, thank you for the possibility to talk with the very nice guys, friends, and I give my now an opportunity for the answer, and if you want to talk again.
Gracias, Luis, por tu participación y coincido con todos los puntos que dijiste. I want to make a question for all the panelists. Dr. Kim, I saw you have laparoscopic, conventional surgery, and robotic surgeries. Do you think we have to start the training of a young colorectal surgeon with conventional surgery, passing after to laparoscopy and after to robotics and after to TATME? Or should we start now the training with laparoscopy, as happened with the cholecystectomy? Now our residents start operating on gallbladders by laparoscopy. Should we do the same in rectal cancer? Dr. Kim, and for all the panelists.
Thank you, Professor Morera Grecourse. First of all, I very thank you for your questions. You know, in South Korea, is the last 10 years, the laparoscope surgery penetration rate, according to each specialty, is over 80%, even 90%. So we very taking careful consideration when you're training the residents and students. But unfortunately, we just to push the resident to the dry lab using only the laparoscope. So as I mentioned, as I was showing my presentation slide, only 20% of total colorectal cancer cases performed by open surgery, most of advanced case. But during that procedure, hopefully my residents learn how to perform the approach to rectal cancer by open surgery. But basically, it's very important to teach the students and the residents about the basic principle of the surgery for rectal cancer, regardless of the surgical treatment modality. Dr. Roman no is concerned about that issues, But I think we usually emphasize whenever you choose any surgical treatment modality, laparoscope or robotic or even TATME, I think in future, new surgical modality definitely appear in the future. But our teachers emphasize the principle of surgery, surgical principle. So that is maybe answer. So I think it's frankly speaking, in South Korea, the robotic surgery for rectal cancer still remain the 10%, because we have many robots in South Korea, but the medical insurance program prohibit us to perform the robotic surgery, different situation from Latin America and Northern America. So that's the reason why the robotic penetration rate still very low. But personally, I think it's a basic principle of surgery can be reproducible, either laparoscope or robotic surgery. Before I finish my comment, I think I'm very impressed Professor Albert's presentation about the TATME. I think we Korean surgeons still behind the TATME techniques, but I think TATME techniques maybe definitely many benefit to surgeons and patients in future time. Thank you very much.
Thank you, Dr. Kim. Antonio, ¿estás en línea?
Sí, estoy acá.
¿Cómo manejan ustedes el training de los cirujanos colorectales jóvenes?
Okay,
really
no,
relaxed.
say that again.
I said he's really relaxed.
I am. You got it. Primero quiero decir gracias por invitarme de manera informal a esto. Me parece muy buena. Impresionante los videos de todos. Y quiero decir dos cosas al respecto. Una, me pareció muy bueno la honestidad del doctor Lagares de presentarnos claramente, decirnos el robot es eso, es un instrumento. Yo en el sitio donde estoy, pues tengo la posibilidad de hacer los tres, tengo la posibilidad de hacer el robot, tengo la posibilidad de hacer TATME, tengo la posibilidad de hacer cirugía laparoscópica y tengo un bias, tengo un sesgo hacia la cirugía TATME porque pienso que tiene una condición única y es que le permite el control del margen distal. I said, Matt, that I believe that TATME gives you a unique feature, which is control of the distal margin, que es algo que uno, en mi opinión, no logra con el robot y creo que uno termina disecando un poco más de lo que tiene que resecar con el robot. Ahora, yo vuelvo al punto de Luis Romanolo, y es la realidad de los países nuestros, de los países de Latinoamérica. Están muy lejos de tener acceso al robot. El 95% de las plataformas están entre Estados Unidos, la Unión Europea y China. Cuando un robot vale 2-3 millones de dólares y llevar a un país como el nuestro, yo vengo de Colombia, un país como los nuestros, y pensar que un cirujano tiene que... Yo vi lo que presentó el doctor Lagares en cuanto a los costos de hacer cirugía laparoscópica y cirugía robótica. En Canadá, nosotros estamos en el mismo coste, pero fue porque una persona donó 3 millones de dólares para dar un robot, regaló los 3 millones de dólares. Entonces, de ahí partimos en cero. ¿Cómo vamos a equiparar esto para los países nuestros? No tenemos cuándo lograr esto. Ahora, ¿cómo entrenar a nuestros cirujanos? Si esa era la pregunta, pues aquí todos los residentes tienen acceso al robot, todos. El fellow de Matt viene de la escuela de nosotros y fue allá y Matt lo aceptó. Y ahorita se está entrenando, pero ya venía con experiencia de cirugía robótica. Yo creo que lo que hay que hacer, en mi opinión, lo que hay que hacer es centralizar el manejo del cáncer de recto. No puede estar repartido por todas partes. You got to centralize management of rectal cancer. It cannot be distributed among like low rectal cancer surgeons. And TATME, robotic surgery, laparoscopic surgery, open surgery, whatever you want, is a tool. Is the surgeon who ultimately will do the operation. Es un instrumento. Quien hace la cirugía, acordémonos que la plataforma robótica no opera de manera independiente. La plataforma robótica es un instrumento de cirugía laparoscópica avanzada. que no es independiente y no es autónomo. Me extendí en mi respuesta, pero quería hacer esas 3 aclaraciones.
Excelente. Jorge Lagares, te hago una consulta. ¿Cómo piensas vos por qué ha disminuido el costo del robot? Porque en los slides que mostraste en los últimos años casi se equiparó a lo de la laparoscopía. ¿Podremos hacer nosotros eso acá en Latinoamérica o por qué vos viste ese cambio de costos?
Bueno, lo primero de todo fue no sé cómo lo hacéis ahí en Latinoamérica o no, pero el sistema nuestro hospitalario, el día después de haber hecho cirugía, nos mandan un correo electrónico que tiene, do you want me to speak in English so the other speakers hear it?
Yes, better for
Professor
Dr. Kim and Dr. Albert.
Okay,
solo entiendo perfecto. Prefiero no hablar, pero entiendo perfecto, okay?
Yeah, but we'll try with Professor Kim and try his Spanish later on. So, so the main thing for us, like in our system, our system is very cost conscious, and this is one of the problems that I had originally when we set up the robotic program down here. So we get an email every day from Utilization Review that tells us exactly the amount of money that you spend. So so the next day after I use the robot, I will get an email saying you spend $150 for instrument A, instrument B, instrument C, instrument D. In the Department of Surgery meeting, all those costs get exposed, meaning that every single surgeon knows exactly the average cost per colectomy. And that now, as is transferred to pay for performance and the cost containment here in the healthcare in the United States, now you're getting exposed to, you have to put that bill out there. That's part of the federal government. So once your costs start going up there, you have to equal cost everywhere. So what we did, a lot of it was the contractual negotiations that we had with, so for example, Intuitive Surgical now allows you to lease the robot. So they only charge you per click. So that has decreased the cost in a certain point, but also, every instrument that you use, they charge you. So what we did is, once you standardize the cost of, once you standardize the equipment that you're going to use, then you start negotiating certain things. Like, for example, am I going to use the staple line? Am I going to use, a 25 or a 29 EEA? It's actually very expensive here in the United States when you compare the cost, of what a normal hand-sewn anastomosis is. So when you start seeing physicians that are doing the transcolonic extraction and a hand-sewn anastomosis, that anastomosis is 1/10 of a cost of what it could be a 29 EEA. So all those things have to be, really taken care of consideration. So from my standpoint, I don't think robotics, unless the platforms become more competitive and they have to fight in price and the cost is going to start lowering down when a second platform in the market comes out, that cost is never going to be as laparoscopy. Even if I try my best, and I've been doing this for a long time, I can't get the cost the same. And Matt Albert knows about it, and I'm sure Dr. Kim knows about it. And there's going to come a time that the insurance company will say, I'm not covering it. I'm not doing it. You really have to show me a difference. And maybe that'll happen, maybe that'll not. But if you come with a second company that kind of lowers the price, maybe that would be a little bit more competitive. But as of it is, I think standardization is the only way you guys are going to be able to cut down the cost.
Yeah, Venki, Muna Krishnan from Chennai, India, often gives the robotic talk. There has similar challenges, cost conscious, and demonstrates he only uses 2 robotic instruments. Have you tried ways like he's shown this multiple times? Have you tried ways like that to constantly decrease cost?
Meaning like using the vessel sealer to do suturing?
Well, I mean, he doesn't use as many instruments. I mean, he puts laparoscope, it saves on instruments in the end. I mean, is that worth it, that approach? Or I see it sounds like you would even sometimes maybe not use an EEA to suture if you could, yeah?
Right. I mean, and more as I'm looking at my prices now, especially now that we went to a per click model, now that we have leased the robots. Now I look at any single instrument that I can cut costs. So if I don't need to use, the 29 EA and I can do a hand-sewn anastomosis, intracorporeally, I just go ahead and do it because it's exactly the same surgery that we used to do open. I'm just doing, I'm just using the tool. That's what I mean, I have a better tool that I can do it. So I don't mind using it. It makes me nervous because, like you said, colorectal surgeons were never very well trained to do intracorporeal suturing, but the ability to do it with a robot is far more superior than what I was doing. I mean, I remember my days in residency, trying to do an Nissen fundoplication, and all I hear was the guy yelling at me. Now, after I got the robot, I still have PTSD from that guy telling me, and now I have the robot. I'm like, I wish I would have had the robot when I was a resident because that would have never happened. So I think, yes, the multi-use, but you're also limited because there's just one company, and it's so difficult to get that cost down because they will not give you multi-purpose equipment. Like if you had a vessel sealer that can cut, that can dissect, that can suture, that can do all that stuff, they'll charge you for it. You can't cut the cost on that.
What about Dr. Lagares not using your vessel sealer? We don't use the vessel sealer very often. For instance, we use a combination of monopolar, bipolar when we need to divide. Right. Don't use the stapler all the time. Like you could minimize those costs, but it's still the cost is significant. Plus, remember, if you're translating that cost to Latin American cost, is 2,000 times more money, or 3,000 or 4,000, whatever you want to call it.
Right, it's crazy.
So it's not the same.
I know it's very difficult. Yes, Luis.
One thing is important to say: the rectum continues the same place in the past. So we need to know how to give opportunity for our residents to treat. Right. So to know, laparoscopy, transanal TME, and robots. I think that's more 10 years. We have 10, 12, 15 robots to help us. But the problem is the culture in Latin America is completely different. We are discussing here, not here, but in Brazil or in other countries around here, how much costs intracorporeal anastomosis or extracorporeal through laparoscopy. One intracorporeal costs $2,000 more time, and extracorporeal $300. So in Brazil, 70% of the population use public health system. Only 30% use private. And the private, not so many insurance pay for the robots. So I believe that only 10% of the population are possible to use the robot. So we have to explain, to train our residents all the tools that is possible. In our hospital, the residents do laparoscopy, transanal, but robot, not yet. Why? Because they don't have possibility to use after when they finish here. So I have to give the possibilities how to work. They know how to robots work, everything, but robots not for residents yet. I believe that is.
So I have a question for, for the panel, because I have an idea how the situation happens in South America, but, you put all those points and I was making notes about it, learning curve, what's the learning curve for a resident to feel comfortable when they come out of residency. And I can tell you in the United States, the residents I get, Matt can tell me anything different. My residents get a PGY 4, And that's the first time they ever sat down to do a rectal cancer. And let me tell you, that is painful. And then not only is painful, it's something that I cannot consciously tell this resident as a PGY5 that he's going to be doing rectal cancer out there. So in responding to Antonio, comment too, is like, do we have to have centers of excellence? The reality is that you should have a center of excellence. When you look at Dr. Kim's results, the only reason why they have a conversion rate of 2 to 3% laparoscopically is because everything gets referred to that center. If you're in the middle of nowhere in Korea, you are not doing a rectal cancer. Everything is going to Dr. Kim's hospital. So by the same token, I think physicians in South America need to put their heads together and go to the political, and the healthcare department and say, you cannot do this because we are not doing a service to our people that pay the Social Security, that pay the public healthcare system. Here in the United States, it's a little bit different, but when it comes down to volumes, and I may be wrong, but I think what is it, Matt? Isn't it still 15 rectal cancers a year, a high volume hospital for rectal cancer? Is that still the number as it stands? I can't hear you.
25. You're muted. You're muted.
Yeah, muted. Yeah, I mean, I can't recall exactly, but yeah, I think more like 25 or so. But more than 80% of the hospitals in the United States do less than 10 of them.
Right.
Yeah.
So anyway, so those were my comments for your questions about that.
Big challenge about what you said is that the reality is in many places, rectal cancer surgery gets done in community hospitals, and that refers to what you said. And in South America, probably there will need to be some sort of a political will to adopt these new technologies, because to believe that there is no future, for instance, in robotic surgery or modern platforms is the same as to say cell phones will not be successful. And cell phones are already successful. The future is in robotic surgery, TME, these platforms. And as you pointed at the very beginning, it all depends on what you have access to and what you feel comfortable with. Keep in mind that resources are not infinite, as many people or many of us at some point want to believe, but they're not. And that is pretty obvious in places like South America. And I know because I come from there, and I'm very conscious about that.
Okay. I feel I'm learning so much, and we can go on for the whole night, but for respect to all the participants, I sadly have had to end the meeting. So Dr. Kim has to go to the operating room, and Matthew also. So I want to thank you all for being here with us tonight. Les agradezco a todos la participación. Podríamos seguir toda la noche hablando con estos especialistas que la verdad nos han deleitado. Eduardo Londoño, si estás conectado y querés darnos unas palabras de cierre.
Gracias, Alejandro. No, I just wanted to thank all the panelists and the people that presented just beautiful presentations, videos for all the time, and especially to be so close to our society. We do enjoy, and we do know that you have a lot of work to do, but thank you very much for your participation. It's always a pleasure to see friends from abroad, and I look forward to have you once again in one of our meetings. Gracias al Dr. Moreira, al Dr. Latif y a todos los organizadores de la LAC, y excelente presentación. Mil gracias.
Bueno, muchas gracias a todos. Buenas noches. Muchísimas gracias. Muchísimas gracias. Fue verdaderamente maravillosa la noche que pasamos. Nos extendimos un poquito en el tiempo, pero valió la pena. Por distintos medios de comunicación pedían que no terminara la discusión. Pero bueno, nos quedaremos con ganas para la próxima vez. Muchas gracias a todos. Buenas noches y hasta la próxima. Gracias, Alejandro. Brillante. Manejar a semejante capo de esto es muy bueno. Gracias.
Thank you
Jen,
for your
gracias,
participation.
Londoño,
Take care.
todos. Caicedo, todos.
Gracias.
Good day, Dr. Kim, and good night for everyone
Okay.
else.
Abrazo.
Un abrazo,
Albert,
gracias,
saludos
Matthew.
a todos. Matthew, saludos.
Bye, Matt.